Hello everyone, I am Marwan and I am glad to have you join me for the third video in our head-to-head comparison series. In this third video, we will dive into loop diuretics, exploring their mechanisms of action, effectiveness, side effects, and primary uses. Don't forget to subscribe and turn on notifications to stay updated on our future episodes. Loop diuretics are a class of medications that consist of four drugs: furosemide, toracimide or torsemide, bumetanide, and ethacryonic acid. Loop diuretics act on the ascending limb of the loop of Hill in the kidneys to inhibit sodium chloride and potassium reabsorption. Therefore, reabsorption of these ions into the renal medulla is decreased. By lowering the osmotic pressure in the medulla, less water is reabsorbed from the water-permeable segments, like the descending loop of Hill, causing diuresis. This action increases urine output, reducing fluid retention in the body. Compared to other types of diuretics, such as thiazide diuretics, potassium-sparing diuretics, carbonic anhydrase inhibitors, and osmotic diuretics, loop diuretics have the most potent diuretic effect. This is because the ascending limb of the loop of Hill is responsible for reabsorbing 25 to 13% of filtered sodium chloride. They are primarily used to manage conditions like edema associated with heart failure, liver cirrhosis, and kidney disease, as well as to control high blood pressure in some cases. They are also indicated for managing hyperkalemia and hypomagnesemia in advanced cardiac life support. Now, let's begin comparing loop diuretics, starting with their pharmacokinetic profiles, where these diuretics differ significantly. Furosemide has an unpredictable bioavailability ranging from 10 to 60% after oral administration. In contrast, bumetanide and torsemide have more consistent bioavailability rates of 75% and 80% respectively. Ethacryonic acid, however, boasts a bioavailability of 100%. Furosemide starts working about 1 hour after oral administration, 13 minutes after intramuscular injection, and within 5 minutes after intravenous injection. The same applies to bumetanide, except its IV onset is quicker, starting within 2 minutes. Torsemide, available only as oral tablets, begins to take effect after 1 hour. Lastly, ethacryonic acid has an onset of action of about 1 hour when taken orally and 15 to 13 minutes when administered via IV injection. The half-life of furosemide is 13 to 120 minutes in individuals with normal renal function, but extends to 9 hours in patients with end-stage renal disease. Bumetanide has a half-life of 1 to 1.5 hours in adults, 2.4 hours in infants over 1 month old, and 6 hours in neonates. Torsemide has a half-life of approximately 3.5 hours. For ethacryonic acid, the half-life ranges from 2 to 4 hours. The duration of action for furosemide is about 2 hours with intravenous injection and 6 to 8 hours with oral administration. Bumetanide typically lasts 4 to 6 hours. Torsemide has a duration of action of 6 to 8 hours. For ethacryonic acid, the duration of action ranges from 4 to 8 hours when taken orally and 2 to 7 hours when administered intravenously. The 2019 Tornado clinical trial by Balsam and colleagues compared toracimide and furosemide in managing fluid retention and improving physical performance. Toracimide outperformed furosemide in both areas. Only 37 of patients on toracimide experienced equal or worsened fluid retention, compared to 58% on furosemide, while 63% on toracimide achieved a significant reduction in fluid retention versus 42% on furosemide. Regarding exercise performance, 63% of toracimide patients improved their 6-minute walk test distance by at least 50 meters, compared to 25% on furosemide. These results highlight toracimide's superior ability to reduce fluid retention and enhance physical endurance. According to another study conducted by Verkud and colleagues in 2024 comparing furosemide, toracimide, and bumetanide, the 6-month adjusted all-cause mortality risk was lowest with toracimide at 13.2%, followed by furosemide at 14.5%, and bumetanide at 15.6%. For the 6-month composite outcome, which include cardiovascular death, heart failure hospitalization, and worsening heart failure symptoms, the risk was 21.4 for toracimide, 24.7 for furosemide, and 24.9 for bumetanide. Loop diuretics vary in their rates of side effects, such as hyperuricemia, hypokalemia, and ototoxicity. Hyperuricemia occurs most frequently with furosemide, 14%, followed by bumetanide, 18%, toracimide, 3%, and ethacryonic acid, 30%. Similarly, hypokalemia is most common with furosemide, ranging from 14 to 16%, followed by bumetanide, 15%, toracimide, 4%, and ethacryonic acid, 13%. Loop diuretics also differ in their risk of ototoxicity. Ethacryonic acid has the highest risk of ototoxicity, with reported rates up to 7%, particularly when administered intravenously or in high doses. Furosemide also carries a significant risk as it causes ototoxicity in 1 to 6 of patients, especially at high doses or rapid IV administration. Bumetanide has a lower risk compared to furosemide, which is only 1%, while torsemide is associated with the lowest risk of ototoxicity among the loop diuretics, with rates typically less than 1% or negligible in most studies. These differences highlight torsemide as having the lowest risk for hyperuricemia, hypokalemia, and ototoxicity among the loop diuretics, making it potentially more favorable for patients at risk of these complications. The rates of hyperglycemia associated with loop diuretics are generally lower compared to other diuretics like thiazides. Hyperglycemia occurs in about 10 to 20% of patients using furosemide, depending on the dose and duration of therapy. For bumetanide and ethacryonic acid, rates are similar to furosemide, reported at approximately 10 to 15%, while torsemide again associated with the lower rates of hyperglycemia, typically around 5 to 10%. Ethacryonic acid is used less frequently nowadays compared to other loop diuretics like furosemide, bumetanide, and torsemide, because ethacryonic acid is more likely to cause ototoxicity than other loop diuretics, especially when used in high doses or in combination with other ototoxic drugs. Also, there's less clinical experience and evidence supporting the long-term efficacy and safety of ethacryonic acid compared to other loop diuretics. As a result, ethacryonic acid is often reserved for patients who are allergic to sulfonamides, which make up the structure of furosemide, bumetanide, and torsemide, as it is a non-sulfonamide loop diuretic. Thank you for tuning into this episode on loop diuretics. We hope it was informative and useful. Feel free to share your questions or suggest topics you'd like us to cover in the comments below. Remember to hit the like button and subscribe to our Daily Pharma channel for more valuable content. Until next time, stay curious and take care.